Dr. Nawal. We are back again with a new topic from Auricle. So, we're going to start with a very interesting topic for today, that is acute and chronic rhinitis, granulomatous diseases of the nose. So, before we continue, I wanted to give a brief introduction on what is Auricle. So Auricle is a 90-day university preparation platform where we prepare students for their academics and also for their next exam and for their NEET PGs and so on and so forth. So this is the topics that we'll be covering today on your screens. The long essay and short essays, we'll try to cover it in 1 hour, 10 minutes and so. Why you should choose Auricle? Because we have recorded classes, live classes, practical sessions, exam modules, and hard copy note sets. Everyone can benefit from it. So recorded classes are, of course, the classes will be recorded and will be present in your applications if subscribed, and you can use them anytime you want. Foundation classes are the same thing. Then we have something called live classes like we are having now, where you will have live online class where you can ask questions and, clear your doubts, if any. So this will be a live class. Express exam module is just like a revision, a crash course where your syllabus will be covered under 20 hours. That is before your exam, of course, just to prepare you for the paper. Then we have one-to-one doubt clearing sessions. These are, again, covered in the live sessions only, that you can clear your doubts and you can clear your topics that you're still not confident with. Hard copy note sets are made by specific educators and professionals. So they pick up what is important for the exam and what is the exam pattern and how you should present your answer. And they just make note out of it. So you can use those hard copy note sets if you're not so much, enthusiastic about reading the textbook. We also have question bank from beginners to expert level. It is a customizable question bank that you can download on your Android apps or Apple, and you can use it. It's for academics, next, and NEET PGs, and also for FMGs who want to write. Practical sessions, we also teach students how to present themselves in the practical exam, how to answer a question to an external, what they can expect from an external, and what can external ask them, and what can they expect to come in the practical exam. So we also train for practical sessions. We have 4 subscription plans here on your screen. You can choose any with the QR code mentioned below for discount. Moving ahead. So today's topic is rhinitis. So the picture that you can see here, on one side, you have normal nasal mucosa. On the other side, you have something called rhinitis. Itis means inflammation in medical term. Pancreatitis, gastritis. Just like that, we have rhinitis. So it is an inflammation of the nasal mucosa. Now here, anyone who had heard our previous classes, we have covered the anatomy of the nose. We can see the upper concha, middle concha, and the lower concha. Atrophic rhinitis. So atrophic rhinitis is actually atrophy. What does it mean by atrophy? Atrophy means shrinking of any sort of muscle or any cell. So when the size of the cell shrinks down, it is known as atrophy. So atrophic rhinitis means atrophy of the turbinates and the nasal mucosa. It is shrinking. The cells in the turbinates and the nasal mucosa are shrinking. Okay, so the nasal cavities are actually in this patient very roomy. Their nose will be big in size in the nasal cavities. So the size increases, the cavity size increases because the walls thin, right? So atrophy means decrease of the size of the cell. So what happens the cavity size will increase. The room inside will increase because the walls are thinning, the turbinates are thinning, the nasal mucosa is thinning. So these patients will typically present with foul-smelling crusts. So this is also known as ozynia. So the atrophy will affect the turbinates, and the turbinates and the nasal mucosa will get atrophied. That is, they will become thin-walled, so it will increase the size within the nasal cavity. And now what happens is that when they breathe in air, a large volume of air gets in, right? When they do inspire air, what happens is more volume of air gets in, and they have a lot of crust building up inside. Now, atrophic rhinitis is of two types, primary and secondary. Both of them have same treatment regardless. Okay. Atrophic rhinitis, primary, secondary. Atrophic rhinitis has one treatment for both of them. Either it is primary or either it is secondary. So the etiologies of primary atrophic rhinitis is hereditary factors. The mnemonic you can use here is hernia. It's mentioned in the DIGRA. So the mnemonic here will be hernia. Okay, hereditary factors. So diseases that are known to involve more than one member in the family. So more than one member will have atrophic rhinitis, maybe mother, maybe sister, maybe grandmother, maybe uncle, right? So hereditary factors play important role here in atrophic rhinitis, followed by endocrinal disturbances. Now, endocrinal disturbances involves more in females than in males. Okay, especially females who undergo menopause. So they will have this. So menopause is a stage where you will have atrophy of all the muscles, of all the cells in the body, your uterus, um, your muscles itself. After you enter a particular age, your muscle starts to atrophy. You shrink in size, right? So endocrinal disturbances what comes in is menopause. Okay, usually seen in females. Now, racial factors, white and yellow races are more affected with this atrophic rhinitis. So you will see it more towards the European and the Western side. Then nutritional deficiencies, of course. So all the vitamins, like vitamin A, vitamin D, can cause atrophic rhinitis because it makes your skin dry, of course, and it leads to atrophy. Now, infections, there are certain infections like diphtheroids. If someone is having diphtheria, these children will also have crusts in their nose, right? So diphtheroids can cause atrophic rhinitis. E. coli can cause atrophic rhinitis. And the most important is Staphylococcus and Streptococcus. Okay, so I'll just write down. Remember that whatever I'm writing here is more important to know than the other things. Okay, so even for your practical point of view. So infections are caused by staph, by streptococci, E. coli, diphtheroids. Okay, endocrine, mostly in female, menopause. Hmm? Then we have autoimmune process. That is the last part, last risk factor. So the body reacts by destructive process to antigens, right? Now, what happens is that if someone is having viral infection or some other unspecified agents, that will trigger the antigenicity of the nasal mucosa and it will cause atrophic rhinitis. Okay. So post-viral infection, we can say post-viral infection. All right. So these are the risk factors of primary as well as secondary. But secondary, of course, it will have a little more advanced risk factors. So moving ahead, so this is how it will look like. If you can see, the nasal cavity has increased in size. Why? Because the walls inside are shrinking. There is atrophy. So if you have a chamber or a box, the cavity size here is, let's say, normal. Now, when the wall starts to thin, when there is atrophy, What happens here? The room increases, right? The room size increases. So this is the mechanism of why do they have big nasal cavities. Okay. To pathology. Now, ciliated columnar epithelium in this condition are lost and it is replaced by stratified squamous epithelium. So there is dysplasia. What happens is that the nasal mucosa actually has ciliated columnar epithelium. Now, this ciliated columnar epithelium is replaced by stratified squamous epithelium. Plus, there is atrophy. There is atrophy of glands, that is seromucinous glands. There is atrophy of sinuses. There is atrophy of nerve elements. And also the arteries in the mucosa, the periosteum and the bone, all of them will start to obliterate. Okay. So there is first of all, columnar epithelium, ciliated columnar epithelium is lost. And the word replaced is important. It is replaced by stratified squamous epithelium. Plus, what happens is that it becomes atrophy. Plus, there is atrophy. Atrophy of glands, that is seromucinous glands. Sinusides and nerves, followed by arteries that will start to obliterate. Now, these arteries are present in the mucosa, in the periosteum, and in the bone, right? So these starts to obliterate. Now, bone undergoes resorption. Now, what happens is that the bone of the turbinates, it will undergo resorption. Now, when these bone undergoes resorption, because it is a process of atrophy, so when the bone undergoes resorption, it will start to widen the nasal chambers. Okay. Now, just because there is widening of the nasal chambers, the paranasal sinuses become small because there is arrested development. Okay. There is an arrest now because it is starting to compress the surrounding structures. So it is important. I'll just repeat the pathology again. The ciliated columnar epithelium is lost and it is replaced by stratified squamous epithelium. All right. Plus, there is atrophy of the glands, of the bloods, sinusides, and of the nerves, followed by arteries undergoes obliteration. The bone of the turbinates undergo resorption, and this resorption will lead to increase in the size of the nasal chambers, followed by paranasal sinuses becoming small. Okay, I hope that's very clear for everyone. Moving ahead, the clinical features. So the clinical features are, you know, it's it's spread around, it's spread and it has a lot of symptoms, clinical features, because this is usually seen post-infection. Okay, usually when a person is having rhinitis followed by atrophic rhinitis. What is rhinitis? It is common cold that we'll talk about later. So it is usually post-viral infection that they have atrophic rhinitis. So you will see that the patient will have symptoms of viral infection. You will see he'll have fever. You will see there is degeneration. He complains of headache. He complains of nasal obstruction and all. So the first and the foremost, the indicative of atrophic rhinitis is that the patient will have foul smell from the nose. Okay. Now, what will happen is that this will make the patient a social outcast. And these patients on top of that will have anosmia. What is anosmia? What is anosmia? They are unaware to smell. They just cannot recognize any smell. Loss of olfactory sensation is known as anosmia. So these patients, what will happen is that they will have foul smell from the nose, plus they will have anosmia. They will not be able to sense any smell, right? So these are major symptoms of atrophic rhinitis. And now what will happen is that these patients will also have degenerative changes. They will start complaining of nasal obstruction. You will see that they have wide nasal chambers, clear nasal chambers, but they will have nasal obstruction. Now, when you see it inside the nose, you will see crust that is inside the nose. And some patients, they will actually come with complaint of epistaxis. What is epistaxis? It is bleeding of the nose. Now, there are two reasons. One, that your arteries, the epistaxis is from the littles area, and the other is that the patient tries to remove his crust and his nose bleeds. Now, it's not a profuse type of bleeding, but yes, it is epistaxis. Okay. So they just complain of, epistaxis whenever they remove their crust. Now, when you do the examination of the nasal cavity, you will see nasal cavity is full of greenish or grayish or black dry crust. Okay. Now, when you try to remove it, this will bleed. When the crusts are removed and the nasal cavities appears roomy, there will be atrophy of turbinates. Now, just because there is atrophy of turbinates, the posterior wall of the nasopharynx can be easily seen. So you will very clearly see the posterior wall of nasopharynx because everything that is on the way has shrunken. There is atrophy there. So you can even see the posterior wall of nasopharynx. Now, nasal turbinates, they will undergo atrophy and nasal mucosa will start appearing pale. Over the time, what happens is that the patient will have septal perforation. Okay. After having septal perforation, the nasal vestibuli may have dermatitis. It will become dry. So these are the atrophic changes you will see. Now, atrophic changes can also be seen in the pharynx, pharyngeal mucosa. They will say that the throat, the pharyngeal layer, mucosa is dry, right? That is known as atrophic pharyngitis. That is a totally different topic. And it might also happen in larynx. These patients may say our throat is always dry, and they might just cough, cough, cough because their throat is dry, and they will have a hoarseness of voice because they'll have atrophic rhinitis. Over the time, what will happen is that they might have hearing impairment. Okay. So all these, it's like a widespread clinical feature in this patients. The clinical features and the management are just similar in primary and secondary atrophic rhinitis. Okay. So you don't have to bother that you have to read the symptoms of primary separately and secondary separately. Both of them will have similar symptoms. It's just that the secondary atrophic rhinitis is because of some other cause. Okay. So clinical features, I'll repeat again, whatever is there on the screen, that the patient will have foul smell from the nose of the patient, but the patient has anosmia. That means they will have loss of olfactory sensation. They will have wide nasal chambers, but they will complain of nasal obstruction. They will have epistaxis on removal of crust. When you open and see the nasal cavity, you will see that there is greenish, grayish, or black crust that is completely covering the nasal turbinates. Now, because there is atrophy of the nasal turbinates, you will see posterior part of nasopharynx. Okay, nasal mucosa will appear pale, and there will be septal perforation and dermatitis of nasal vestibuli. The pharyngeal mucosa will appear dry. These patients might have complications of atrophic laryngitis. If becomes chronic, can lead to hearing impairment. And over the time, what happens is that the walls of the sinuses will become thick. Okay, so these are the clinical features of atrophic rhinitis. Now, coming to the treatment part, it is divided into two, like you see on your screens. Now, the first is medical and the second is surgical. The medical is a complete cure of disease. Okay. Now, what happens is that you make sure that you treat the patient conservatively before you take him to the surgical department. So the first thing you do is nasal irrigation and removal of crust. If you see here, this is called nasal irrigation and removal of crust. So you make sure that there is warm normal saline or any alkaline solution that is made by dissolving 1 tablespoon of salt in water, and then the solution is run through one nostril and it comes out from the other. If you have seen it on internet, you will just understand. You can just have a brief that, okay, this patient might have atrophic rhinitis just because he's doing nasal irrigation, but it's not specific. Okay, so that's nasal irrigation. But you just irrigate the nose, you clear the block, right? And the saline will help to just control the inflammation of the nasal mucosa. Okay. Now, you should make sure that you should guide the patient that he should not push the fluid inside the sinuses, because this is a very common complication post nasal irrigation, that the patient will push the fluid into their nasal sinuses directly and come with a new sort of infection or a pain, because through those sinuses, the fluid might even enter into their eustachian tubes. Okay, so they should be repeated 2 to 3 times in a day, or you can give 25% glucose and glycerine. So after you remove the crust and the nose, and then what you do is that you slowly apply 25% glucose in glycerine. What does this do is that this will inhibit the growth of proteolytic organisms. These organisms are responsible for foul smelling. Okay, so I'll just write it down for information. Proteolytic organisms responsible for foul smell. In this case, you use glucose and glycerine, 25% glucose and glycerine. So what does it do is that it will inhibit the growth of proteolytic enzyme. You can give local antibiotics like spraying or just applying in the nose like topical antibiotics, and this will help prevent secondary infection and then helps prevent the patient to slide into the secondary cause of atrophic rhinitis. Okay, so antibiotics usually they will contain also vitamin D2. It helps because it's an oil-based vitamin, so it helps. Local antibiotics. Something called ostradiol spray. Now, what does ostradiol spray do is that it will increase the vascularity of the nasal mucosa. And what it will do, any cell that will have increased vascularity will have increased blood supply. And when any cell in your body has increased blood supply, it will have increased oxygen, and that oxygen will lead to regeneration of the cells. Okay, so this is the normal physiology that every doctor should know. So it helps to increase the vascularity of the nasal mucosa, and that will lead to regeneration of seromucinous glands. So ostradiol spray will actually help in regeneration of ostradiol's seromucinous glands by increasing the vascularity of the nasal mucosa. I'll just write it down here. Regeneration of seromucinous glands. Okay. Now, sometimes you can also use systemic streptomycin 1 gram per day for 10 days. Now, this has proven to give good results to reduce crust and odor. And these are actually, you know, usually used after doing culture. And after you find out that the patient might have atrophic rhinitis because of Klebsiella organisms, streptomycin will work wonders. Okay, so systemic streptomycin is effective against Klebsiella organisms. All right. Now, coming to the surgical part. The surgery includes, there's one procedure called Young's procedure. So Young's procedure, both the nostrils are closed completely. And what will happen is that they are open after 6 months or later. Now, in these cases, mucosa will revert to normal and crusting will be reduced. So actually what happens in atrophic rhinitis is the columnar epithelial cells are replaced by stratified squamous epithelial cells. So what will happen is that the surgeon will raise the nasal vestibuli flaps. They'll cut open and they'll raise the nasal vestibuli flaps and they will completely just block it. They'll just close the nostrils completely. And after 6 months, what happens is that this progression will stop because you're just cutting off that process of changing of the cells and atrophy. And mucosa will revert to normal and crusting will be reduced. Now, there's other sub-modified Young's procedure. Now, this is more commonly used now to avoid the discomfort of bilateral nasal obstruction. Now, modified Young's operation aims partially closing the nostrils. Okay, and it has same benefit as Young's. So Young's procedure was done before, but now they usually use modified Young's procedure to avoid discomfort, and you partially obstruct the nasal parts. Okay, now this has significantly helped to improve the nasal hygiene and reduction in crusting. And also the patients may lose the ability to breathe through their nose until they are reopened. Now, this is one complication of that. So that's why modified Young's procedure, partially closes the nostrils. Now, the other way is narrowing the nasal cavities. So what you do is that the nasal chambers are very wide in these patients with atrophic rhinitis. And what happens is the air is entering into the nasal cavity with larger volume. The air currents are very high in volume and they are dry. So what is actually happening is that they are also, evaporating the secretions. Now, these secretions, when they get evaporated, they are becoming crusts. So when you narrow the size of the nasal airway, what happens is that the adequate amount of air will enter into the nose. And this will help to relieve the symptoms. Now, how do you do that? You give submucosal injection of Teflon paste. Now, not everyone knows it, but it's there in DINGRA if you want to just have a detailed information about it. So you use Teflon paste to inject. Number one. Number two is that you do insertion of fat or cartilage or bone or Teflon strips. So all these cosmetic surgeries, just to decrease the size of the nose, right? So you can insertion of fat or Teflon strips or whatever. Or what you do is that you little bit, if it is unilateral, now this is usual when it is unilateral. If let's say it's on the left side, what you do is you slightly uh, displace the medial part of the lateral wall. Right? So you slightly displace it so that, it decreases the nasal cavity. It's less popular. Usually the cosmetic surgeons do these procedures where they inject Teflon paste to decrease the nasal size, nasal cavity. All those cosmetic procedures were actually are actually used for these type of patients. But then, so you can see here that the nasal vestibuli flaps are being raised. You can see here. And then you pack it so that you stop the conversion of columnar epithelial cells into stratified columnar epithelial cells. Right? See. Modified Young's procedure. This is Young's procedure. Now, modified Young's procedure is just you keep an opening here. Secondary atrophic rhinitis is specific infection like syphilis. Now, I have told this in the beginning that primary and secondary atrophic rhinitis both have similar symptoms, and both of them should be treated similarly regardless of their names. Secondary atrophic rhinitis, specific infections like syphilis, lupus, leprosy, all these, infections, what they will do is they will destruct the nasal structures and they will lead to atrophic changes. Okay. So what you do is that you have to treat them in a similar way. Usually these patients treatment is surgical procedures. Sometimes some patients undergo radiotherapy, right? Radiotherapy to the nose, and that will lead to atrophy because radiotherapy leads to atrophy of the cells, right? So remember, atrophic rhinitis, two types, primary, secondary, both of them has one symptom, one type of clinical features and similar type of management. Now, coming to the next topic that we have is deviated nasal septum. So what does it mean by deviated nasal septum? So deviated nasal septum has types. Anterior dislocation, you can see here, it is anteriorly dislocated. C-shaped deviated nasal septum, S-shaped deviated nasal septum, and you have spurs followed by thickening. So all these are types of deviated nasal septum. So these patients will have clinical features like nasal obstruction. Now, if it is unilaterally on one side, what happens is that the nasal septum will be, let's say, deviated on the left side, So what happens? these patients will have obstruction on the left side of the nose. So let's go to the clinical features. There will be nasal obstruction depending upon the type. If it is anterior, they'll have different type of nasal obstruction. If it is a posterior, unilateral, they will have different, or if they'll have bilateral, they will be different. Now, respiratory currents will pass through upper part of the nasal cavity. So septal deviations will cause nasal obstruction. Remember this. So when you examine the patient physically, what you see is that there will be obstruction in the nose. Either it can be vestibular, or it can be at the nasal valve, or at the attic, or at the turbinates, or at the corner. Okay. Uh, Coming to the next clinical feature that we have, headache. So deviated nasal septum, especially spur type of nasal septum deviation, that may press the lateral wall of the nose and it will start to increase the pressure and cause headache. So how does it look? Spur. This is how septal spur will look like. So if you can see, it is compressing the lateral part of the nasal septum, right? Now this what will do is rise the pressure and cause headache. Followed by sinusitis. So deviated nasal septum may obstruct sinus. And this sinusitis is a very painful condition. The patient will have pain in their face. They'll have headache all the time. They'll be irritated and there will be poor ventilation of the sinuses. So the patient will have open mouth breathing. Okay. So it forms an important cause of predisposing sinus infections if it leads to sinusitis. The other thing is epistaxis. So the mucosa over the deviated nasal part of the septum is usually exposed to drying because of the air current. So now imagine if it is unilateral and the nasal septum is deviated towards the right side, the nasal cavity, the room inside the left has increased. So the air current flow will increase and it will lead to crust. Now this crust will lead to bleeding. It is somewhere related to atrophic rhinitis, similar to atrophic rhinitis. These patients might also have anosmia because what happens is that the olfactory region may not get that inspired air. Your olfactory region, olfactory nerves are on the tip of the nose, right? So these patients might have failure of olfactory function. External deformity you might see in some patients, they might come for a cosmetic appearance saying that my nose is deviated towards left or right, or it's crooked a little bit here and there. Okay. Some patients might also have middle ear infection via the eustachian tube. Treatment. So treatment of deviated nasal septums varies according to the degree. Minor degrees of deviated nasal septums are usually asymptomatic and they do not require any treatment. Okay. Because deviated nasal septum procedures like mechanical nasal obstruction or the symptoms are indicative for operations. So the only way you can straighten a crooked nose is through a surgery or an operation. So this surgical procedure is known as submucous resection operation, SMR we say. So it is generally done in adults under local anesthesia. So what does it do is that we elevate the mucoperichondrial or mucoperiostean flaps on the either side of the septal framework. So here on both the sides, you just open the flaps, mucoperichondrial and mucoperiosteal flaps by making an incision. And if there is any deflected part of the bone, we just remove it. Or if there isn't some extra cartilaginous septum, like just like in case of spur, we just remove that. We reposition the flaps and we just suture it back. Okay. There's other procedure called septoplasty. Now, it is a very conservative approach to septal surgery. What happens in this procedure is that the septal framework is retained. So the only most deviated parts are removed. So if the deviation is most commonly on the left side, you just remove that. So the rest of the septal framework is repositioned by plastics, all right, prosthetics. So mucoperichondrial or periosteal flap is raised again here, but you on one side, not on both the sides. And what we do is that we retain the attachment and the blood supply on the other side. And septoplasty is most commonly now replaced by submucous resection operation. Okay, so septal surgery is usually done after age of 17, preferably advised to get it done after age of 17 so that there is no obstruction in the growth of nasal skeleton, right? So after you hit puberty, it is most commonly advised. But if a child is having severe nasal obstruction, like in cases of spurs, and they are having recurrent sinusitis because of deviated nasal septum, or let's say they are having obstruction and difficulty in breathing, then it is advised to do it ASAP. Okay. So this was about deviated nasal septum. See, this is before and after procedures of surgeries. You remove the cartilage. So if you see 1, 2, 3, you just remove the crooked cartilage and you just fix both of these. You replace both of these and it becomes a reshaped septum, right? Now the procedure is a submucous resection operation. And septoplasty is where you just remove everything and you replace it by plastic, commonly used now by cosmetic surgeons. Now, what is Oriza? What does it mean by, it's not Oriza, it's Coriza. See, Coriza. What does it mean by Coriza? So, acute rhinitis. So, rhinitis is inflammation of the nasal mucosa. So, acute rhinitis can be either viral, can be bacterial, or can be irritative type. Irritative type means you have runny nose because of allergies. Bacterial means you have runny nose because of bacteria. And viral means you have runny nose because of viral infections. Okay. Now, common cold is known as coryza. So doctors actually, they don't say common cold, they say coryza. So what is coryza? It is a viral rhinoceros. It's caused by virus. Okay. So these patients will have viral infection. The infection is because of some airborne droplets like adenovirus, picornovirus, rhinovirus, Coxsackie virus, so many other viruses we have. All these viruses, any one of them can cause common cold. Now, the symptoms will start 1 to 4 days and it will last for 2 to 3 weeks. So the incubation period is 1 to 4 days. Here it's mentioned the incubation period is 1 to 4 days and the illness lasts for 2 to 3 weeks. Okay. The clinical features is that the patient will have burning sensation, right? So they will say this burning sensation in my nose and I cannot breathe because I feel it's burning sensation in my nose. Then eventually they will start to develop stuffy nose, followed by rhinorrhea. Then they will have sneezing. Now, what will happen is that then systemic, symptoms will come in. They will have chills. They will have low-grade fever. Then they will have nasal discharge. First, initially, it will be watery. Then it will become mucopurulent. If it is because of bacteria, it will become mucopurulent. Then, what happens is that there, in some cases, what happens is that there may be secondary bacterial invasion like Streptococcus hemolyticus, Haemophilus influenza, Klebsiella and all. Okay, so there are steps. First comes burning sensation, then comes nasal obstruction, followed by rhinorrhea sneezing. After that, system hits in chills, fevers, usually low-grade fevers, followed by nasal discharge. Initially, it is watery, followed by it is mucopurulent. Now, if it is mucopurulent and the patient has very poor immunity, secondary bacteria will invade it. And it can be Streptococcus hemolyticus, Haemophilus influenza, Klebsiella pneumonia, anything. Okay. Remember that incubation period is 1 to 4 days and illness will last for 2 to 3 weeks. Okay, it is self-resolving. Now, these patients are advised to take bed rest. You do not have to get dehydrated, okay, because this is because of low immunity. So, bed rest will play an essential role to cut down this type of illness. And you should ask them to be dehydrating themselves, drinking plenty of fluids, and mild juices and all, which is not harsh to their throat. right? So you ask them to take plenty of fluids. And the symptoms are usually controlled by antihistamines. If this patient is having a lot of sneezes and he's just not able to tolerate and his nose is itchy, it's watery, just cannot, he's very disturbed with this, we can give him antihistamines. And if he's having obstruction, give him a nasal decongestant also. Now, analgesics can also be used to relieve headache, but make sure you give them non-aspirin analgesics. Okay, there are two types of analgesics. Just one is aspirin and one is non-aspirin. Usually in US, what happens, usually in developed countries, what happens is that parents usually get over-the-counter aspirin for their children. And this child will, over the time, develop race syndrome. Okay, so read what is Ray's syndrome. It's like a new information for undergraduates. So just go through what is Ray's syndrome. So you should make sure that the patient takes a non-aspirin containing analgesic for this type of common cold. Because what happens is that when you take a aspirin, it will start to increase the shedding of virus. Okay, so it is going to worsen the situation instead of bringing it down. So make sure you take analgesics that are non-aspirin if you want to take aspirin. Now, antibiotics are required when secondary infections are there, or else otherwise it is not required. You can just conservatively manage them by asking them to take bed rest, giving them fluids, putting them on antihistamines, and if they have body ache, myalgia, and all these symptoms, give them analgesics. Complications, usually not there. It is self-limiting. It will just recover within 2 to 4 weeks. Okay. But if it complicates, it can cause sinusitis, pharyngitis, tonsillitis, bronchitis, pneumonia, ear infection, otitis media, all those things. Okay. So these are the information that you're supposed to know about common cold. Coryza, etiology, clinical features, treatment, and complications. Now, what is rhinitis caseosa? So, rhinitis caseosa is an uncommon condition, usually on one side and mostly affecting male. Okay, it usually affects male patients. Now, the nose is filled with purulent discharge. Now, this purulent discharge is also foul smelling. And this discharge is not watery, it is not mucopurulent, it is cheesy material. Looks like cheese and coming out from the nose. Okay. Now, this is usually because of chronic sinusitis in immune compromised patients like diabetic patients and, patients with HIV and all. So it is because of chronic sinusitis that rhinitis caseosa sets in. Now, what you see here is that the nasal mucosa becomes granulomatous. This word is important, granulomatous. So it's a granulomatous condition. Okay. Bony walls of the nose, usually it will get destroyed. And then you will have to differentiate it from malignancy. You have to confirm it if it is malignancy or not. And then how do you treat it? It's a surgical procedure. You treat it by removing the debris in granulation tissue and make sure if there is pus, you drain off the cheesy material and the affected sinus. Now, these patients, they do not have a bad prognosis. They usually have good prognosis and they usually cover up. So you can see here white cheesy material inside the nose. And you can see inflammation of the nasal mucosa as well, right? Seen in commonly male immune compromised patients. So I think we are done. Thank you for watching. Keep following us for more.